just an honor to speak to all of you, and I was at breakfast telling on my table I'm a little nervous this morning because you guys are the experts, and I'm in medicine, but have been concerned for a long time about safe drinking water, and I'm a pediatrician at Boston Children's Hospital, and so we have a promise to our children that things in the future will be safe. And I remember growing up, there was never any question about the purity of your drinking water, the safety of your drinking water. And now perhaps there is some question. I'm the co-director of the Region 1 Pediatric Environmental Health Specialty Unit, affectionately known as PESHUs. And here is our website. We're a network of environmental health specialists based in academic medical centers. There's one in every region, so all of you have access to a regional PESHU if you need help or have questions. We provide free clinical consultations of all sorts, outreach and public and professional education on pediatric and reproductive environmental health topics. Clinical consultations we provide, and what Steve asked me to talk about a little bit this morning are some of those clinical consultations that have come our way. And so another title for this talk might be Good Wells Gone Wrong, and we're going to talk about that in a little bit. I have nothing to disclose. The PESHUs actually are supported by the EPA and its sister agency, the ATSDR. Worldwide, polluted water and poor sanitation kill about 1.4 million people every year. And this is a Gallup poll that was done a few years ago about environmental concerns of people across the country. And the poll showed undoubtedly that Americans are concerned about the purity of their water. And water pollution remains a top environmental concern in this country. So what I'd like to talk a little bit about today and get some feedback from you on this, since again, you guys know this area much better than I do, is I'm going to list a few chemical and microbial contaminants of drinking water and describe the clinical effects that we see of common water contaminants, especially in children, and outline some strategies. Whoops, just lost it. Oh, there it is. Outline some common strategies that families can use to improve the safety of drinking water. What we're suggesting could be topics of clinical care and child care for physicians and nurse practitioners, et cetera, elsewhere. Anybody recognize this? Okay, everybody recognizes it. This was one of the first epidemiologic studies that was done, and this has been the modern version where they kind of colorized it. And this, of course, was John Snow, who was responding to the cholera outbreak in London in 1854 in his neighborhood, Soho neighborhood, and he actually went door to door. And he asked people, where do you get your water? Which well do you use? And do you have any cholera in your house? And for there, he was able to show that the Soho neighborhood's outbreak was due to a single water pump at Broad Street. And he curbed the cholera outbreak by getting rid of that particular pumping, having them get their water from somewhere else. So that's kind of a historical perspective of what happens, and this is it's a while back, but when I first got to Boston Children's Hospital, I was contacted by the Cape Cod Planning and Economic Development Commission. I'm not sure if all of you have been to Cape Cod, or it's on the coast of Massachusetts. And in 1983, the Economic Development Commission told us that organic chemicals were being detected for the first time in drinking water in increasing amounts from the sole source aquifer all over Cape Cod. Nowadays, about 15% of Cape Cod's population, about 15,000 households, use private wells for drinking, and it was probably less back then, but there was still this concern as to where were the impurities in this water coming from. These are some of the common contaminants that you all know about in terms of microbes, especially Vibrio, Shigella, Salmonella, coliforms, and E. coli, organic chemicals. I'll talk a little bit, and I see later in your conference talking about PFAS, inorganic chemicals, including lead, arsenic, nitrates, and nitrites, and then others such as TTHM, salt, and radon, which are also contaminants of water. So we began to look at the Cape Cod situation, and we asked where there might be source of these organic chemicals. Where are they coming from? What industry? And as you can see in this slide and these cartoons, the sources of water pollution include industry, mining, and the military, agriculture, urban and rural runoff, sewage and wastewater, natural contaminants, and landfills. And we went through all of these for Cape Cod and found that, frankly, no major industry, no mining, no smelting, no landfills, no large agribusiness, no urban cities. It's nothing like that on Cape Cod. That's a puzzle. So where was it coming from? There was a military base, the Joint Base of Cape Cod. It was 5 different military commands, parts of Falmouth, Bourne, Mashpee, and Sandwich, which are all little towns on Cape Cod. And didn't seem that it was coming from the military base since it was widespread. And so we did research and we set up a household hazardous waste collection program in Cape Cod. And at the time, and it's still true, a lot of the inhabitants of Cape Cod, not involved with the tourism industry, are craftsmen, are painters, are small business owners. And so for the first time, we set up a hazardous waste collection program. And you can see here the little stars on this map are where we had collection sites where people could turn in any household waste that they had. And we wondered whether that might make a difference. Cape Cod, if you know it, is kind of a sandy, gravelly soil, and it's a sole source aquifer, and it percolates very easily. So if you pour your used motor oil in your backyard, you're drinking it, within the next 48, 72 hours. And so in 1983, we kept kind of an inventory of what people turned in. And you can see here, it was phenomenal. 2,484 gallons of paint, arsenic and lead arsenate, which they used in the cranberry bogs. People had stored lead arsenate, and they turned that in. Liquid pesticides, chemicals, solvents, fertilizers, solid pesticides, all sorts of things in this cleanup. And we, partnered with Clean Harbors, the agency that could dispose of these things responsibly in a manifest. And so that was the first hazardous waste cleanup for households. And it made a difference in terms of what was getting into the aquifer. And even, this is from last year, they do that same cleanup 4 times a year. They've been doing it since 1983. And I show it simply to point out to you that there's many different ways we can make a difference in improving water quality and ensuring that people's water is risk-free, relatively risk-free. Threats to water, as you all know, there are many of them. And just to spend a little bit, there are threats to disadvantaged communities, threats from disasters, and threats that we can attribute to climate change. Disadvantaged communities are especially at risk in our viewpoint in terms of tribal communities. Those minorities that have been redlined, that is, they have historical discrimination in terms of where they live and where they're able to get a mortgage. Families who are disadvantaged, who have closer proximity to landfills and Superfund sites, since that's all they can afford to live near. Proximity to industry and agriculture, and rural families that y'all are very familiar with. And then there are disasters. If you've, even within the past couple of days out here in Montana, I've already heard about the smoke jumpers and the wildfires that they prepare for out here in the West, and wildfires certainly can affect the integrity of private wells. Drought, inadequate aquifer recharge, food and water insecurity and dehydration are other problems that are seen the world over, only getting worse due to climate change. Violent storms, flooding certainly interrupts access to water, and we're beginning to think that part of our mission as pediatricians and pediatric nurse practitioners and healthcare providers is to make families more resilient to disasters and having them prepare for disaster circumstances. And we all know what has happened in Asheville and Chimney Rock, North Carolina, Tampa, Florida, Clearwater. This graph on the slide, the bar graph, shows the frequency of Category 4 and 5 Atlantic hurricanes, which seems to be increasing over time due to climate change. And you are from districts that may have been impacted by disasters like flooding. One instance, after flooding of the Ohio River in Kentucky in 2011, the surface water contained higher levels of E. coli, other microbes, arsenic, copper, iron, lead, so et cetera, related to the flood. Nuclear events, the Fukushima earthquake and tsunami and the nuclear reactor meltdown. There were increased levels of cesium, strontium, and plutonium in tap water that were detected for months. So many different disasters, and we are thinking as to how to prepare families in the event of a disaster. Climate change, extreme weather events. We've talked previously about drought and flooding, wildfires, temperature changes and rising seawater, changes in saltwater intrusion and salinity, surface water runoff, the leaching of contaminants, altered water consumption and aquifer recharging are all a part of climate change and are by this point probably irreversible. You can see in the graph on this slide the atmospheric carbon dioxide content, which has stayed very stable for some millennia until recently, where since 1950 it has probably doubled, if not tripled. So with that background, I'd like to talk to you about a couple of cases that we've seen, and I know that these are going to be familiar to you, that some of you, especially those in public health, have experienced some of these. And I just want to give you our perspective as a clinic when we see families with these issues, or at least have a clinical consultation about these issues. Okay, so this is our region. Received a call from a family in Maine. They were notified in 2022 that there was arsenic in their well water, very common in the Northeast. They installed a reverse osmosis and a water softening system, and there was a discovery by them in February of 2026, 4 years later, that the system had stopped working. They had not changed the filters, and they were unsure as to how long it had been non-functional. So they switched. They switched to bottled water, and the arsenite, the arsenic +3 cation, was greater than 300 parts per billion, whereas the EPA's MCL is 10 parts per billion. And actually, the MCL in New Hampshire is 5 parts per billion for arsenic. So much elevated in their well water. They have a 2-year-old daughter. They were concerned for gestational exposure since they don't know how long their treatment system had been ineffective. And so I would ask you, and certainly this was asked of us, how would you counsel this family that they've been exposed, who knows how long, but possibly even for a few years, with elevated arsenic in their water? We know that children are more vulnerable in these types of events. Young children consume 7 times as much water per pound of body weight versus adults. They get a higher dose, therefore, of toxins pound per pound. They certainly have a longer lifespan, so occult and delayed medical outcomes may not arrive before adolescence or adulthood. Infants drink formula, often mixed with water, and up to 36 ounces a day. Young children's skin is more permeable than that of adults, and the GI tract and other organ systems, including the brain, are still developing, and that makes children more vulnerable. Certainly there are increased water requirements during pregnancy and during lactation, and the placenta is permeable to many of the toxins that might contaminate water and thus affect fetal growth and development. Arsenic, as you know very well, is present in groundwater and drinking water. It's odorless and tasteless. Geologically, it runs with copper, but it's in granite, shale, limestone, rock formations. It is the #1 contaminant at Superfund sites. There are many different forms of arsenic. So the ones that we're concerned about were the ones that were affecting this family. That is arsenite +3. Arsenate +5 is toxic, but not as toxic as arsenite, and that is sometimes the arsenic that has been found in contaminating foods. There's also arsenious acid and arsine gas, which are seen much less often, and usually in occupational settings. And then the 2 others, arsenobutane and arsenylcholine, are conjugated arsenic, and those are the kind that we frequently find in foods, especially seafoods. Much less toxic, hardly any toxicity, and they'll still show up in the urine as arsenic, which is why when you get a urinary arsenic level, you need to speciate it to see what kind of arsenic you have. Is it +3? Is it +5, or is it conjugated? Y'all know about pesticides and lead arsenate, which was used in apple orchards and cranberry bogs, and to get rid of the boll weevil in cotton. Arsenic was also sold commercially, taro ant syrup, where you had a little bottle of arsenic and you put it on a cotton ball and you left it in the corner for the ant to get and for your 2-year-old to get. And that was a source of poisoning from arsenic. And then, as you all have read in the paper in recent years, baby foods, rice, brown rice syrup, apples, all have been identified as potential sources of arsenic. And these are some of the clinical effects, some of the early signs, not universally present, but certainly present in less than half the cases of arsenosis, are skin signs. So palms and soles, so-called melanosis or keratosis, skin lesions and discolorations are frequently the early signs of arsenic poisoning. And then later signs are neurologic, including arsenic can cause stroke, neuropathies and cognitive deficits. It's a known carcinogen, not only of the skin, but of the bladder, lung, prostate, and liver. And you can see in this map of the US the incidence of bladder cancer in the United States, and you can see us up in the Northeast. We have our problems with arsenic in natural sources and the incidence of bladder cancer among the population. It's also been associated with diabetes, chronic obstructive pulmonary disease, bronchiectasis, another pulmonary disease, Blackfoot disease, which is a vascular insufficiency of the extremities, and it's certainly toxic to the fetus. So many different clinical effects from arsenic that we see and that we examined this family for, since we didn't know how long they had been exposed to how much arsenic in their drinking water. And when we see families like this, when we do clinical consults like this, we do a comprehensive history. So we're looking as to whether or not they have any arsenic pesticides. Do they smoke? You know, cigarette smoke gives you small amounts of arsenic along with thousands of other chemicals. So we're looking for all sources of a particular toxin or a pollutant when we interview families like this. And in this case, what we suggested was that chronic low-level arsenic exposure can have adverse health effects, including possible carcinogenesis. And if the family uses well water, that they should periodically test the water for arsenic and impurities, install reverse osmosis filters or NSF-approved devices as needed, and importantly, and this should be bolded, keep filters changed per manufacturer's instructions, which this family overlooked, and it's natural. If you've not lived in a home with a well before, and then you bought a home and you start living there, and you have a well with reverse osmosis, and nobody tells you to change the filter, you may not know to change the filter, and that can be tragic. For symptomatic arsenosis, like the slide I just showed you, we use chelation therapy. Chelance comes from the Greek chelikos, which is crab-like. So it surrounds the contaminant in the blood, and then they excrete it in the urine. We used two chemicals for arsenic, although one is rapidly disappearing in the United States, BAL, also known as British antilewisite. The manufacturer went out of business, and supplies have not been identified. But we do use an oral drug called dimercaptosuccinic acid, or DMSA, which is effective against several heavy metals, including lead, but also arsenic. A little toxicology hack when I'm speaking to other audiences, but also to you, is for chronic arsenicosis, giving supplemental folic acid, 5 milligrams daily, reduces the excretion of the toxic arsenite and converts the toxic arsenite to the less toxic metabolite, dimethyl arsenic acid, or DMA, which is then increased in the urine. So simple 5 milligrams daily of folic acid is not the whole answer, but at least it can help for families with chronic arsenic poisoning. Moving on, this is another case from 2014. Our PESU was consulted about a 4-year-old in good health. The mother worked at New Hampshire's Peace Trade Port for 10 years and during her pregnancy. The child was in daycare. There are 3 daycare facilities in the trade port, and the mother heard the water was contaminated with PFAS for over a decade, and she wants her child's blood tested for PFAS. And the question is, should she get it tested? It's an expensive test. This is the Peace Trade Port in New Hampshire, which was an old military base which was closed and turned into a commercial trade port. after the Peace Air Force Base was closed in 1970. While the Air Force was there, they were using AFFF, which is a PFAS-containing product to put out fires, especially airplane fires. And then they left, and today there are over 250 businesses there, 2 daycare centers, over 9,000 workers. The EPA asked the Air Force to test the 3 wells serving this Air Force base. And you can see the little table on the right. The Haven well of the 3 wells that were tested was above the EPA's limits at the time, provisional health advisory of 0.07 micrograms per liter. And we actually did a study, not specifically for this family in terms of blood testing, but testing over 1,200 people in the trade port for PFAS back in 2014. And these graphs show you 3 of those chemicals, PFAS, PFOA, and PFEX, with the Peace trade port numbers for children and adults circled. Just above those are NHANE data, that is general population levels of those 3 contaminants. And at the top are known other PFAS contamination sites in the Ohio River Valley, in Alabama, and in metro Minnesota. And you can see the blood PFAS levels in the contaminated sites at the top of each graph versus those at the Peace trade port. And this pointed out to us that when you have water contamination, you don't always get all of the PFAS contaminants elevated. And if you look at this graph, the PFOA and the PFAS, not too bad at the trade port. They're about what the NHANES values are. But when you look at PFEX, they are markedly elevated. So there indeed was a PFAS contamination problem there. And this was one of the first New England epidemiologic studies to document the relationship between blood testing and drinking water contamination. I'm not going to answer this question. I posed it because we as health professionals are asking ourselves this very question. And you're going to, I think, hear on Thursday that there might be some possible answers to the question. You're going to hear more about PFAS at your Thursday meeting. But I'll leave it to you. Who do we test for these chemicals? When communities are found or private wells are found to have elevated PFAS levels in them, what do we tell families? And there's a lot of uncertainty in terms of medical outcomes after PFAS exposure and the relationship of those medical outcomes to blood levels. So we're still learning. There's still uncertainty, and people don't like to deal with uncertainty in medicine. They want answers from us. So I'm going to leave that one for you respectfully and move on. This is another case that I'm sure you've known about. We were called about a 3-month-old male presenting to the emergency department, cyanotic, a blue baby with respiratory distress. Family lives near a farm. The baby's pulse oximetry ranged between 85 and 88%. It's supposed to be in the upper 90s. And the child was irritable, lethargic, short of breath. Put irritable and lethargic twice. So doubly irritable and doubly lethargic. Had some loss of consciousness and actually was seizing. And this is a little bedside test, unapproved by any federal agency, where you run a little oxygen through a blood sample and see if it turns bright red. And you can see on the other slide, this chocolate brown appearing blood does not respond to oxygen because the hemoglobin is no longer either deoxyhemoglobin or oxyhemoglobin, veins and arteries. Instead, it's methemoglobin, which is oxidized and cannot be oxygenated. So that's the diagnosis for blue baby syndrome. That is methemoglobinemia, which is usually seen at greater than 10 parts per million of nitrates in the water, and is related to how infants break down their microbiome, the bacteria that is in their gut, reducing the nitrate to nitrite, which is much more toxic, and that establishes the conversion from hemoglobin to methemoglobin, and little babies have lowered amounts of enzymes. They haven't developed their full complement of methemoglobin reductase, so they can't move it back to hemoglobin like older children and adults can, so you get these little blue babies. And what's fascinating is the babies come in, they're blue. We show the families the antidote, which is methylene blue, which is blue, and then we run it through the IV, and they can see the blue material running in, and they can see the babies changing color to pink. So blue, blue equals pink. And that's the treatment for blue baby syndrome, is methylene blue. Another case, and this you might see, and this is instructive to us as health professionals, in that this family lives in a rural area. They were evacuated during a serious flooding event. The community has since recovered. They're now back home. Their 5-year-old was diagnosed with GERD, gastroesophageal reflux disease, and is back in the physician's office today because of abdominal pain. Their 3-year-old is lactose intolerant and has recent onset of diarrhea, and both parents have recently complained of some heartburn and loose stools. So this should be a signal to us as healthcare providers, because there must be a common source point for these complaints if we recognize them in the family. It's like a family that comes in the fall in the Northeast, and they all seem to have flu-like syndromes. They're all achy. They all have some vomiting. They all have, some lethargy. And you think, it must be a virus, must be the flu. Then you find out that their furnace was recently turned on, and they're actually suffering carbon monoxide poisoning. So whenever you get many members of a family suffering the same kind of illness or the same kind of symptoms, start to look for a common source point and not be thrown off by GERD or lactose intolerance or something else. And this was the result of their well water. And you can see here the total coliform and the E. coli content of the well water results in this case were elevated. And so the family could not drink this water. This water is non-potable until the bacteria are cleared. And that should clear up the family's symptoms and GI complaints. Okay, I have another case, and this is a 7-year-old previously well Canadian female. And she spent the summer at their cottage in a rural locale in Canada. And it was noticed by August that she had pica, and that is the ingestion of non-food items, which we often see in little kids. And it usually extinguishes by age 3 or 4 in little kids. They stop putting, paper and things in their mouths, and because they've learned from us as parents that you should put food in there, but sticks and stones and things, no, don't put that in your mouth. A real problem in children on the spectrum, autistic spectrum, and because they can retain those pica habits well into childhood, school age, and even into adolescence in some cases. But this child previously didn't have this, but started to eat paper goods. She'd sneak toilet paper to eat. She would suck on her shirt or on a teddy bear. In August, by September, she'd regressed. She started wetting the bed at night. She could no longer write her name or draw detailed pictures. For a 7-year-old, she became shy and withdrawn. She would get stuck on words. She would stutter and have difficulty with word finding. She had socially inappropriate behavior. She put fingers in her eyes, eye, mouth, nose, crotch, licking fingers, wiping the floor, licking again, licking dirty surfaces. Her homework papers had bites around the circumference. Teachers noted her inattentiveness and lack of focus. Her pediatrician saw her and did a screening blood count and found her hemoglobin to be markedly elevated at 18.6. Normal is somewhere between 11 and 13. That is the concentration of hemoglobin in her blood. And she had a very low ferritin level, which is another measure of the iron in your blood and the iron in your marrow. By October, she had episodic sudden loss of tone, frequent tripping, ataxia, and she adapted by lying on the ground to read. She had trouble getting up from the lying position, and by November, she was hospitalized. She had deteriorating gross motor function. She was unable to walk more than 1 or 2 steps without falling. She had brain and abdominal CT scans that were normal. Her CBC, her complete blood count, showed an elevated hemoglobin still at 19, an elevated hematocrit. In other words, her blood was quite thick with hemoglobin, and an elevated mean corpuscular volume, which is the size of her red cells. Whereas her iron, normal is 50 to 150, her iron was only 5, and her ferritin, which should be 10 to 50, was less than 10. That is, she did not have any iron in her bone marrow. What's going on here? This was a real clinical conundrum for us, and they had consulted many subspecialties and us, and we investigated the environment like we always do. So the family home was in proximity to wetlands and a distance from the town water main, prohibited connection to town water. And in my conversations with Steve, he would wonder why you couldn't figure out some connection to municipal water in this case. They had drilled a well and they had drank the well water for 5 years and never tested it. And y'all know about that. That is a problem. Their water was turbid, it had a metallic taste, it had orange-brown residue that was left on clothes, dishes, and appliances. The family also went to another part of Canada and spent 3 months of year at their cottage for 4 years. The cottage also had turbid well water and was never tested. They grew vegetables in the cottage garden, and it was the mother who noted, it's funny, when I water the vegetables and water the garden, the leaves have this kind of coppery sheen on them. So, I wonder what's in our water, and they finally got the water tested. And what they found in the water was elevated manganese levels. These are blood levels for the mother, the father, and the patient. And you can see their lead levels were fine, their cadmium levels were fine. The adult normal blood manganese level is about 0.7 mics per DL, and the patient, the little girl's manganese level was 4.478, one of the highest that we'd ever seen, as opposed to the mother and father, although the father's was getting up there too, in terms of it was 0.93 mics per DL. And as it turns out, the city water manganese level was 0.04 milligrams per liter. Their well water was 2.4 milligrams per liter. The cottage manganese level was 2.5 milligrams per liter, and the EPA recommends 0.3. And we measured manganese in the extended family, and all of them had elevated serum manganese levels. We biopsied the liver of the little girl, and the manganese in her liver was markedly elevated. So she had an elevated body burden of manganese. And as it turns out, this was not a just manganese contamination issue. This was a genetic issue. This child had mutations in her ability to handle manganese that were also present to some degree in other family members. So this wasn't a straightforward manganese case, but I bring it up just to remind you all about manganese as a potential toxin, a neurotoxin. Certainly an essential mineral as well. It's in our diet. It can be in the water. It can be a cosmetic problem in the water. There are occupational and industrial exposures, and it can be in some pesticides. And if you look at the periodic table, manganese, iron, and cobalt are pretty close as so-called transitional metals. Dietary iron +3 is reduced to iron +2 in the brush border in your small intestine, and that's transported across a particular receptor called the DMT1. The DMT1 is not monogamous. It will also transport manganese. It will transport lead. It will transport other +2 cations. And you can see in the little cartoon how that happens through the brush border at the top and then through the receptor, the DMT receptor. So manganese neurotoxicity is well known in terms of affecting birth weight, affecting infant development, motor development, visual spatial memory, and visual memory. This child, beyond the birth weight problem, had cognitive and developmental outcomes that were affected by manganese. These were her CT scans, which showed the top are the manganese toxic, and you can see radiodensities in the basal ganglia, in the white matter, and the brainstem, consistent with manganese toxicity. We actually chelated this child with sodium, potassium EDTA, and after several bouts of chelation, the bottom are the same CT scans, and I think you can see, even grossly, that the areas lighting up are a little bit less than they were before. So the chelation was getting rid of some of this manganese, and she was making some neurologic and developmental progress, but at considerable expense and time in terms of the amount of chelation she required. So what I've done is shown you some of the cases that we've seen in our practice. And for me, going back to 1983, when I become involved and interested in clinical effects of water contamination. And so how should we counsel families as health professionals? With your help, how should we counsel families? During well child care, we want health professionals to ask parents where they get their drinking and cooking water. And we want them to give parents key advice on ensuring safe water, including testing your well, preparing for emergencies and disasters. Recommend that families with a well get their water tested for safety, that they should use cold water for cooking and preparing formula, and if it's possibly contaminated, use filtered or bottled water. If there's in doubt about bacteria, boil the water and check state and local water advisories. This is what we think health professionals across the country, not only Boston Children's, should recommend. Should I test my drinking water from my well? Well, I was elected to write, along with my team, a policy statement for the American Academy of Pediatrics a few years back, drinking water from private wells and risk to children. And in the end, we came out with policies that the AAP recommends now, that well water should be tested annually for coliforms and nitrates, that it should be tested for total dissolved solids and pH, every 3 years for chemicals, every 5 years for solvents, other tests as recommended locally. And additional testing might be needed for newly built or reconditioned wells after a flood or a disaster, if you have a newborn in the household, if you repair or replace any part of the well system, it should be tested. If conditions near the well have changed, land disturbance, new industry, et cetera. If there's a change in the color, the odor or the taste rather. If it's turning your leaves coppery sheen, test it. If there are known problems with groundwater or drinking water in the area, and depend on local and state health departments to give further guidance for well owners. Should we use bottled water? We think it's not necessary if you're using a reliable water system that meets governmental regulations. There's as you all know, the environmental impact of plastic bottles. It doesn't contain any fluoride for infants. They're exposed to toxic chemicals such as phthalates and bisphenol A. For immunocompromised families, they want to make sure that even that water is treated with filtration. But it may be necessary as a temporary water source if there's a problem with your well, for example, coliforms. And here are some of the environmental impacts of plastic bottles and so forth. So I appreciate your attention this morning. And just to finish up, on a positive note in terms of all of us and our role as advocates for safe drinking water, going beyond individual cases or even individual communities. Here in Massachusetts, the House Committee on Environment and Natural Resources recently voted favorably on an act to protect drinking water quality in private wells, House Bill number 900. This bill would set standards, promote testing, and provide resources to well owners to bring wells into compliance. It would provide protections so that the more than 500,000 Massachusetts residents who rely on private well water can trust that it's safe. So we're advocating for this progressive legislation, and we feel that's a part of how we keep kids safe and make sure that we fulfill our promise to them of safe drinking water. And thank you very much for your attention this morning.
So the questions are right here. So you're just free to go through them.
Okay.
Everybody can see those too.
Yeah, so just a few questions and answers to talk about this. Our physicians usually involved with identifying exposure sources, or is it usually handled more by local health board and EPI offices? I would say it's usually handled by health departments, certainly at the community level. And y'all know that for some identified contaminants at the community level, certainly from municipal sources, they are mandated to report to all of their customers if their lead has exceedances of EPA's requirements. If their PFAS now exceeds the MCL at the state level, they need to send a letter to every customer in that community. And if you read that level, and I've read them for lead and for PFAS and other chemicals, it says at the bottom, if you have any questions, contact your healthcare provider. So the families do. And when they contact their own pediatrician or pediatric nurse practitioner and say, we were notified our PFAS level was too high, what do you think of that? And usually, for the average health professional out there, that's a head scratcher. We need to do a better job of professional education in terms of how do you counsel somebody who comes to you with elevated uranium in their water or arsenic or lead or PFAS. So that's important. So physicians can often be asked those questions, but frequently don't have good enough answers, in my opinion. Are there any reliable or trustworthy resources for medical issues versus possible water, specifically groundwater quality issues? Absolutely. There's EPA guidance. There's ATSDR tox files and tox reviews. There are sources, for example, the American Academy of Pediatrics puts out resources on medical issues, and in fact is coming out with their 5th edition of the so-called Green Book, which talks about medical conditions due to the environment. So there are some trustworthy resources, but you have to be careful in this age of social media and the internet in terms of what's trustworthy and do they have scientifically based, referenced findings and recommendations. I recently had a case of elevated lithium in a well over 100 parts per billion. What would be the medical concerns to be investigated and discussed? Lithium is an excellent treatment for bipolar disease and is kind of a first-line therapy for some medical cases like that, but you can also get lithium toxic. And lithium toxic certainly can cause neurotoxicity, even to the point where we dialyze patients who have elevated lithium levels. So certainly, if there's a concern like this, the first thing would be if the patient is having any neurologic symptoms, and you can get a blood lithium level and see where they are. Are you currently seeing babies that have blue baby syndrome? Public health in our state doesn't track it, so we don't know. Many people in the public tell us that blue baby syndrome is a disease that no longer exists. Not true. So why are we worried about nitrate in drinking water? Nitrate hasn't changed, nitrite hasn't changed, babies haven't changed. And the combination continues to be problematic in some cases. And I'll point out, methemoglobinemia is not just due to nitrites. Y'all have heard of baby Oragel that people put on their gums. Some babies, are very sensitive to benzocaine in baby Oragel, and benzocaine in toxicity can produce methemoglobinemia too. Pyridium that's used in some urinary tract infections. We had a case of a child who was mistakenly given an adult dose of pyridium, and this chemical can also oxidize blood and produce methemoglobin. So there are other sources of methemoglobin besides blue baby syndrome, but it hasn't gone away. It's still there on the books. The slide showed fluoride as an issue in 6 to 12 months. What is that risk? Fluoride is controversial. The current recommendations of the American Dental Association and the American Academy of Pediatrics are that kids benefit from fluoride and fluoride-containing varnish that dentists will use, and it protects against caries. It reinforces the matrix of the dentine. You can also get fluorosis, that is too much fluoride. And I don't know about at 6 to 12 months of age, that's when you start to require fluoride in terms of tooth development. And so sources of fluoride at the proper dose shouldn't be a risk, but combination of too many sources of fluoride and excess fluoride can affect bone growth and cause a condition medically that we know is fluorosis. There's been some controversy about whether fluoride has neurotoxic effects, still very controversial based on a Canadian study that may have problems with it. So that one's still out there. What is the most prevalent contaminant that you are seeing right now? You know, this is great for me. I usually do these, you know, you do webinars via Zoom, and at the end, there may be 200 questions that people are asking, and it's a great part of the conversation that we have with each other. The most prevalent contaminant that we're seeing right now in water, you know, I've got to say it's PFAS. And it's because it's a front burner issue. It's all over the media, and towns are now mandated. They weren't mandated before, but now towns are mandated to inform their customers if they find PFAS in city water, and private well owners are now, it's a strong suggestion that they test their wells for PFAS as well as other contaminants, and they're finding it. And so those cases get referred to us as to what to do about that. My office often gets questions from other state agencies who oversee child care, foster homes, et cetera, asking which water tests they should require for licensees. Is there standard guidance or recommendations for this from the medical side? I'm not sure, and I'm going to push this one back at you. You guys are the experts, and you know, and some of it is dependent on local geography, right, and local conditions as to what's prevalent in that community. And it may be a problem in New Hampshire, which is one of the reasons they lowered their MCL for arsenic from 10 parts per billion to 5, but it may not be a problem in another area or another state. So we have no, beyond what I read in terms of the American Academy of Pediatrics policy for what you should check yearly, every 3 years, every 5 years, you really should go by state and local guidance for what they're requiring from municipalities. Why should private well owners be any different? We suggested testing for lead as well, especially in homes with children. Our research has found elevated lead levels in homes as new as 2014. Question, what about recommendations for microbiological concerns, boiling, and high levels of metals that may lead to increased concentrations after boiling? Yes, if it's microbes, it's one thing. If it's microbes and lead, I'm not sure what you do, but you don't drink that water. If it's only lead, don't boil it. We did some of the research that said boiling it just concentrates the lead, so don't do that. For families, I'm not sure, and you guys know better for me, you know, lead is not going to come from the well itself, right? It's going to come from pipes and solder inside the home. And, you know, one of our recommendations for family, it's certainly not a fix-all, is run your tap water for 4 or 5 minutes, first draw in the morning. That'll flush the pipes of any lead that might have leached overnight. And then hopefully that'll make the problem better. Point of use filters, refrigerator filters, as long as you keep the filter changed, are pretty good for lead. Last question. Rhode Island is currently looking into changing our manganese regulations to be more strict, largely for child health. I will send you my slides, or you have my slides. Have you seen similar cases in adults, or is it primarily seen in young and vulnerable populations? I don't want to give you the impression that we see manganese all the time. The case I presented to you is exceptional because that child also had genetic abnormalities that set her up to be more vulnerable to cation exposure. But we also think manganese is a neurotoxin. So, and it's a cosmetic problem. We all know for for water, it changes the taste. It can change the color. it should be regulated. And I think, as I recall, and you guys can correct me if I'm wrong, we decided at one point to replace tetraethyl lead in gasoline with manganese, right, as an anti-knock ingredient, and we would then pollute our environment with manganese instead of polluting it with lead. And then that was quickly abandoned. But I'm all in favor of Rhode Island making its regulations more strict. Again, thank you for your attention.